Well, welcome everybody. I'm delighted here to welcome our guest lecturer for this morning, Dr. Tim Ihrig. I'm going to place a link in the chat box, and somewhere during the course of the lecture, you might want to just copy that and stick it into your browser to look at later. Tim has been a champion for the cause of hospice and palliative care for a long time. Once he figured out what he wanted to do in life, he had spent some time in Los Angeles trying to be a stand-up comic, and fortunately that didn't work out all that well for him, and decided to go medicine. In the midst of that, he served on the U.S. Olympic cycling team, and so he's got a diversity of interests and fun things, but mostly he's just a dear friend and colleague, and I just really appreciate Tim over the years. And he's a compelling speaker. What I'm going to put in the link here, the link that I'm going to put in the chat box, is a TED Talk that brought him to international prominence. That, I don't know, last I checked, what, 1.5, 2 million views on that one. Tim, you probably know. I know that you keep your clicker going every time you're on at it. So
that's why I have carpal tunnel.
There you go. So without further ado, I welcome Dr. Ihrig, and looking forward to your lecture for the fellows today.
John, thank you so much. And to everybody on this morning, thank you for the opportunity to chat with you. John is not only a mentor, but also a dear, dear friend, and I have learned a lot from him. You are all so very fortunate to have him as a resource and a guide, and just a very cool, hip, and groovy human being. So please take advantage of everything you can while you're with him.
Tim, we don't use the word groovy anymore. We sort of phased that out around 1971.
Okay, all right. He's a hell of a guy. How's that? We'll go from there. So thank you for the introduction. Just like to talk with you today about respiratory difficulties, dyspnea, cough, secretions, and hiccups. And when I lecture, I usually present from my lived experience and try to integrate what it's like as a provider to identify, to translate, which I think is one of the key things we are as physicians and human beings, is to translate the clinical realities with the patient's lived experience. Why are they experiencing X, Y, and Z? How can we help them understand not only their symptoms, but in a broader sense, their disease process, and identify what is sacred to them so that we can align the clinical realities with their health trajectory so that they can live their lives. I will move on after this last statement that for me, everything we talk about is shifting the narrative of healthcare from dying, which is an absolute inevitability. Check the box, I respect it. But shifting it to how do you want to live, love, learn, and grow with cancer, heart failure, IPF, whatever it is. And so when we start to shift that narrative, we give control where control can be given. We help people live their best lives for a day, week, month, year, decade, in spite of disease states, in spite of things are changing not as they would have anticipated prior to whatever they're dealing with. So let's get started. Please feel free to ask questions as well as heckle. So this is originally adapted from a good friend and colleague in fellowship who's actually an attending, Gary Shen, when I was in training out at Stanford. We're going to review pathophysiology and treatments of dyspnea, cough, respiratory secretions, and hiccups. I don't dive too deep on dosing and this and that. Again, I want to talk about the lived experience, how to recognize, how to translate, and all that stuff is readily available as far as dosing, etc. That's why we have our good colleagues in pharmacy. Dyspnea, what is it? Let's talk about the physiology, cognitive aspects, excuse me, and emotional factors. We're going to talk about it's not just oxygen. So I've had the experience, as I'm sure all of you that someone can have an oxygen saturation of 92% and feel profoundly short of breath. And as just straight up clinicians, we say, well, how is that possible? They're oxygenating. And we've had people who have an oxygen saturation in the low 80s and they feel completely comfortable and they don't feel short of breath. And when I think about this as a gateway to understanding our patient's lived experience, I think about when I was a kid and I would run with my friends and run and run and run and run and then fall over in my backyard, gasping for air with my side hurting and laughing and not feel short of breath. The gasping and trying to catch my breath manifest from I ran as fast and as far as I could, but my brain was recognizing I have the capacity. I will catch my breath. It's not impeded or limited by any physiologic ailment. And then when I think of how is it possible that somebody that has an oxygen saturation in the low 80s doesn't feel short of breath? So I think of my soon to be in a couple of weeks 17-year-old son who is now taller than I am. And I look at him and don't recognize the significant growth and change over the last few years. But when we have friends who haven't seen him in 5 years come and say, wow, you've grown 1.5 feet over the last couple of years, their change is a different perspective than the day to day to day, which a lot of our patients experience. This slow incremental change over time where their body adjusts and their new norm 5 years into congestive heart failure or pulmonary fibrosis is much different than if there was a change overnight. And so we have to understand how people understand and perceive their shortness of breath so we can partner with them on their journeys. Tying into that, being a little kid and running till you can't catch your breath, or when, as John said, I was trying to make a living as a cyclist, trying to chase down Lance Armstrong, and I would feel profoundly short of breath. I didn't feel as though I was suffocating because the body has this amazing physiologic mechanism to release endorphins so that you feel, again, like you're not suffocating when you're exercising and pushing yourself beyond the limits. Opioids, to understand as a mainstay for treatment of dyspnea, or shortness of breath, work in a similar manner. They work in the mu receptors throughout the limbic system and efferent pathways to help us feel as though we are not profoundly short of breath. The pool experiment, and there's been several, but the one I'm referencing was shared with me by Dr. Shin years ago, that there were individuals who were placed in a swimming pool and they were asked two arms of this experiment. One arm was asked to hold their breath underwater for 30 seconds. So it was proven that they could hold their breath above water for 30 seconds. And so they went underwater and held their breath for 30 seconds. And there were questions about their subjective experience. And nobody felt as though they were short of breath. Nobody felt any emotive component to that 30 seconds of holding their breath underwater. Conversely, the group that was held underwater for 30 seconds and had proven that they could hold their breath for 30 seconds above water, they had an emotional reaction of a sensation of shortness of breath, a little bit of anxiety. They knew cognitively they could hold their breath for 30 seconds. But the fact that they were being held underwater, they didn't have the capacity to come up for air, added a whole new dimension to their lived experience. And I think that's really key in us understanding some of our patients' journeys. If you can hold your breath for 30 seconds and you are in control of breathing, not breathing, that is certainly one level of control. If that is being taken away from you, even though you can hold your breath for 30 seconds, the subjective feeling is much, much different and can lead to anxiety. As we know, a little bit of dyspnea can lead to anxiety, can lead to more dyspnea, and it's kind of a roller coaster. It's our opportunity to understand the root cause, translate it to the patient, and offer them care choices pursuant to what's sacred to them to help them feel better. So we know in the body there's a lot of chemoreceptors, oxygen, CO2, mu, kappa, delta, sigma. These are all the things that are affected by various disease states and the agents that we use to help mitigate the sensation of dyspnea. Again, we touched on mu receptors, mainstay for treatment of dyspnea pharmacologically. And my sandbox is opioids, and that's where they work. Again, they don't significantly change how you breathe. They just allow you to feel more comfortable with where you're at on that capacity of breathing. Now, certainly if you give anybody enough opioid, you can suppress their respiratory drive. We're going to talk a little bit about being smart and finding your opioid of choice at the home base and initiating and titrating it in a very appropriate manner. So more physiology, you have pulmonary vagal afferents. Remember, afferents are those signals that are coming from the body to the brain, as opposed to efferents, which are exiting, efferent for exit, exiting the brain and going to the body. You have stretch, irritant receptors. So think of you inhale something and say, particularly here in Oklahoma, it's still 90 degrees and we're in the height of a lot of hay fever, other respiratory issues. You inhale something and it makes you short of breath, you cough. That's a signal from the body saying, hey, let's deal with whatever's going on at the present time. There's also alveolar C receptors. So in the actual pulmonary tree itself, you have signals to the brain. So you have this constellation of things that can influence someone's perception. And remember, in the setting of big ticket items, pulmonary fibrosis, lung cancer, end-stage COPD, CHF, etc., people can still have common cold. People can still have hay fever. And so this constellation of things can exacerbate baseline sensation of shortness of breath and other symptoms that people experience. You have a lot of mechanical receptors in the chest wall as well. So what is your capacity to actually do the work of breathing? Can you take a deep breath? Do you have the strength to do such? That all influences your perception of how you're breathing. And the limbic system, anterior insula of the limbic system, is where we in the brain actually perceive, integrate, and make sense out of our lived sensation of breathing and other emotive components of our lived experience. And so that's where all these signals come and allow us to process it. So part of our job as providers, right, is to talk people down off the proverbial ledge. And we'll talk about non-pharmacologic agents, having someone relax, kind of go to their happy place, take some deep breaths. What we're trying to do is influence that limbic system and the emotive response to that sensation they're experiencing. Now, as an aside, 20 years of practice, if we empower people to understand what's driving their lived experience, their negative symptoms, if you will, it is at some level giving them a sense of control, understanding, empowerment of knowing what's going on and why helps somebody have a little bit of control. And I've felt that if I can sit down and walk somebody through why they're experiencing shortness of breath, then cognitively they can say, okay, this is what's happening. I have a little bit of control non-pharmacologically to understand and try to calm myself down and not let it escalate from that dyspnea, anxiety, more dyspnea, more anxiety, more dyspnea. So really important to understand this, Phil, and find a way to translate it through your own voice to help patients as well as their caregivers and family understand what's going on and why. Same with pain, right? I've had many times throughout my career, somebody say, I'm in so much pain, can you just give me that little pill to end it all? When we talk through it and empower somebody to understand why they're having pain and what we can do to give them a sense of control, pharmacologically, non-pharmacologically, educationally, then they have a sense of being able to live their lives, love, learn, grow, regardless of their disease state. Very, very important. So how do we evaluate people who have this sensation of shortness of breath? There's a Borg scale, a visual analog scale, much like the pain scale. We say 1 to 10, 0 being no pain, 10 being the worst pain you could ever imagine. Where you at on the scale? Know that it exists. I personally have never used it. People feel like I'm real short of breath. I'm more short of breath. I feel like you can't breathe at all. So if you have some mechanism, whether it's a Borg scale or other language to help identify the change over time in your patients, their lived experience again, how they are feeling as far as severity of dyspnea, so you can see if your interventions are effective or not. That's, for me, that's the most important thing. From an examination perspective, this is 100 level physical exam. What is the rate of breathing? Normally, you and I, just sitting here, breathe about 6 times a minute. If somebody comes in and they're breathing 40, there's something wrong. And our job is to evaluate why and figure out what we can do. What is the work of breathing? WOB, work of breathing. Does someone look uncomfortable? Are they breathing in a paradoxical fashion? Do they have retractions? Do they have pursed lip breathing? Are they leaning forward? Do they look cyanotic, right? That's another physical finding. Use the work of breathing, the pattern, Kussmaul breathing. Is there profound periods of apnea? Sounds, is there any stridor? Any secretions? All these things help us understand how we can serve our patients better. And I work a lot on the inpatient side of my program with people who are transitioning to comfort measures only, and they're not able to verbally describe what their sensation is. If they're having pain or shortness of breath, many of them are obtunded. And so we need to use a physical exam to make some clinical judgments on, is there an opportunity to engage with some pharmacologic intervention? And again, identify these physical exams to help patients, families, and caregivers be a conduit to helping us care for them. Do they look comfortable to you? It's a question I use a lot. Does it look like mom is just kind of sleeping? Yeah. Does she look comfortable? She does. Okay, fantastic. If that changes, please let me know. And to let people know, particularly at the end of life, that apnea is very common. Sounds may change, patterns may change. I encourage patients, families, and caregivers to not necessarily breathe along with the patient, because sometimes patients have 30, 40-second periods of apnea, and that can be consternating for those at the bedside. But empower them to know the natural progression of change over time so they feel comfortable with this journey. What tests can we do? Well, medicine itself is a linear algorithm of escalation of clinical intervention, and that includes testing. Simply put, x-rays, rely on those. We have PFTs, give us a baseline understanding of somebody's physiologic capacity and what the underlying pathophysiology is, restrictive, obstructive lung disease. A simple oxygen monitor. Let's get a thing on the finger to tell us what their oxygen saturations are, can be indicative of what's going on and how we can treat them. And in your mind, as you start to meet people, understand what the differential is. Is this solely a physical ailment, COPD, CHF, etc.? Is there a component, psychological component? Is there anxiety? Is there anything else that's influencing someone's ability to breathe or the sensation of breathing? So the mainstay in my corner of the world, as far as treating dyspnea, is correlating with all my other providers, particularly pulmonology and opioids. I have a role to talk with patients and families about opioids as a first-line treatment, that it is not the opioid epidemic, that the way we use them is appropriate lots of experience, and here's how we can move forward safely. I have the same conversation with a lot of my pulmonologists because they're often skittish excuse me, to initiate any use of opioids outside of actual end of life. But in our outpatient clinic, I parallel with my colleagues and say, this is how we can help them live better and longer and not show up in the emergency department as frequently and not be ringing your phones off the hook because they feel there's this profound change. I would encourage all of you, opioids, big topic. It's like ice cream. There's lots of flavors. Find one you're comfortable with. Find one or two you're very, very comfortable with and familiar with the pharmacodynamics. Try it out while you have the opportunity and training and you have the oversight. Get familiar with converting, say, morphine to dilaudid, etc., vice versa. Start low, go slow is a mainstay for anything in the geriatric population. I usually have the opportunity in the inpatient setting to have a discussion about utilization of opioids for dyspnea, and it's a controlled setting. So let's give it a try. Let's explain to patients and families how it works, that our expectation is it's not going to change the pathophysiology of their underlying disease states, but may just allow them to be more comfortable with what they're dealing with. So we're going to give you, let's say 1 milligram of sublingual morphine. And what I'd like you to do is tell me if it affects your sensation and how long that works. And then if they say, oh, I didn't do anything, I say, okay, maybe we just don't have the right dose. If they say, wow, it knocked me out completely, and the family is saying, yeah, that's not for us now because you snowed them. My response is, were you able to wake them up? Oh, yeah, we shook them and they woke right up. Well, that's different than snowing somebody. My goal is to allow somebody to be very, very comfortable. Given when I see them, they've usually been struggling, and their work of breathing and their work of staying alive has been such an exorbitant effort. If I allow them to be comfortable, my expectation, my hope is that they would take a big, long power nap because they're tired. And we're taking that negative sensation, decreasing it enough so that they can be comfortable and their body will do what it needs to do and wants to do, which is rest. If I'm able to wake them up readily, I have no concerns that I've overshot the mark as far as dosing. So again, all of this is important in the translation to patients and families when talking about opioids or any other pharmacologic agent. Which route really depends on where you're at. Easiest route for me in the acute inpatient setting is IV. I've got it, might as well use it. We have sublingual, we have pills, subcutaneous. Just know that there's lots of ways, lots of delivery mechanisms that patients can receive pharmacologic agents to help them live better. As far as anxiolytics, they can be profoundly effective too, as far as alleviating the sensation of dyspnea. I tend to lead with an opioid and follow with an anxiolytic. I never stack them, just based on experience that 1 + 1 can be a little more than 2 sometimes, particularly your benzodiazepines. Non-benzodiazepine anxiolytics feel much more comfortable with and can alleviate a lot of patients and caregiver stress and concern as far as addiction, over-sedation, etc. But the combination can be really, really powerful. Again, recognizing shortness of breath can lead to anxiety, lead to more shortness of breath, more anxiety, and it just kind of crescendos. There's other drugs in our repertoire as well that can be appropriate. And I usually discuss these things with other providers, particularly oncology, if we're talking about steroids. Pulmonology, seek their advice with respect to nebulizers. Do we have an infection that is exacerbating the underlying disease state and causing us to be short of breath. So antibiotics can be appropriate. Simple things like diuretics. You got congestive heart failure and you're filling up with fluid. So let's get to the underlying cause and see if we can help somebody feel better in addition to or in lieu of using opioids or anxiolytics. And then oxygen as well. Does this actually, if someone is hypoxic, improve their oxygenation and their lived experience of feeling less short of breath? A lot of times, the oxygen, especially at end of life, is something that placates and makes patients' families and patients' caregivers feel more comfortable. Again, understanding everything we're talking about and being able to translate it to all parties involved is important, because sometimes oxygen may, prolong dying process, may be not beneficial to someone who's actively dying. And we know that, kicking that oxygen saturation up to 96, 97% in a COPD may not be in their best interest as well. So understanding all of this and being able to translate it is important. Non-drug interventions. We talked about cognitive behavioral therapy. A lot of times I just sit down, hold somebody's hand and say, look me in the eyes. I've got you. You're safe. Let's just try to take a slow, deep breath. Let's just relax in a calm voice. Being the provider that can come into a situation and bring calmness is profoundly important and powerful for that lived experience of our patients. So to know this stuff, to practice it while you have the opportunity, so you can walk in the room and you don't feel short of breath. You don't feel anxious. You can come in, sit down, look the patient, everyone in the room in the eye and say, it's going to be a little better. We're going to work together. Energy conservation. Why do people go to cardiac rehab? Why do people go to pulmonary rehab? To improve the fitness of their biologic organism, of their body, so that they use less energy to do the, just kind of work of staying alive, heart rate, breathing, and blood pressure. So if they have the capacity in a very watched and mindful manner to try to get a little stronger, so that it takes less energy to do the things to stay alive, that can be very beneficial. Our job is to watch them over time, because there's a point beyond which everything we do can have a negative physiologic consequence, regardless of intent. And so just say, well, let's go try to train for the Senior Olympics. You don't feel so short of breath because you get, you take your body to a higher level of fitness. Our job is to make sure we're not wearing them out. Positioning. A lot of times people lean forward while they're sitting up. A lot of times people have 2-pillow, 3-pillow orthopnea. It's important to question, how are you most comfortable? How do you sleep at night? You sleep in a recliner. For me, I'd say my wife makes me sleep in the garage. And so there's really no bed and just curl up in the corner. So these things are really, really important. Sometimes a fan, just having that cool air, or an open window, encouraging people to sit in a room where they can have some cool air coming through, can help people feel a lot more comfortable. Non-invasive, positive pressure ventilation. I would encourage all of you, while you have the opportunity, to try a non-invasive positive pressure ventilation mask on, so you can experience what a lot of our patients experience. I am not at baseline claustrophobic, but when I've put a mask on, whether it's a full face mask, the pig nose, or something that covers the nose and mouth, it is very uncomfortable for me. And again, it helps me relate to what patients are experiencing when they say, I can't wear that mask. Can't wear that mask. And so we can collaborate with them to find ways to help them live better. If people are not familiar with acupuncture, I would almost bet my career on it, as well as acupressure. The last 20 years, for all kinds of negative symptoms, I have sought and offered and encouraged utilizing acupuncture and acupressure I've had significant positive experience. Acupuncture generally can be self-empowering. There are meridians that you can map out the foot. You can empower people to try this at home. There's really no downside to this. And a lot of times people say, yeah, whether it's a placebo effect or it actually works is irrelevant to me. If their lived experience is improved, fantastic. Interventional procedures. Again, let's get fluid off if we can. I'm sure John has experienced this, but back in the day, I used to do paracenteses at home. I would go and drain fluid off. Not so much anymore. Wouldn't do a thoracentesis outside of the hospital. I'm not that good. Talk about opportunities for pleural catheters, stenting, radiation therapy, etc. Let's use every modality at our disposal to try to alleviate any negative sensation. And this is really any part of the continuum. We need to really explore risk versus benefit, align it with where someone's at on their clinical journey from a physiologic perspective with what their goals are. So I'm going to pause right there. Stormed through shortness of breath, and I'm a little short of breath from talking too fast, and just see if anybody has any questions, concerns, or philosophical observations. Just drop it in the text box. Heckling is often allowed as well.
Picture somewhere.
We're off mic, so if we want to talk on mic, like this.
Is it a comfortable garage?
I have made it such. Yes. Anybody else? Any questions?
Yeah, I just want to echo a couple of things that you did mention, Tim, and I have a unique perspective having lived with IPF and understanding what it is not to have breath. I understand what it's like when you talk about the mask. That was real to me because there are times when it was either going to be a cannula or it was going to be a mask to get me what I needed in terms of oxygen content. And I think how you shaded that was interesting because I've never considered myself claustrophobic, but you put that mask on me.
Mm-hmm.
And even now, if I go in for a bronch or whatever procedures I have to do, which I still have to do on a fairly regular basis, when I get into anesthesia, they can't give me that first hit fast enough, so I don't have to be conscious of that of the trappings of the mask. And so, sometimes technically that might deliver a better level of oxygen, but I'm much more comfortable riding at a lower, PCO2 or PO2 with the cannula than I would be with the mask at a higher level of O2. So I just like the kind of shading that to what works with the patient, what makes them comfortable, and what really works for their unique specific dynamic.
I could take
Go ahead, please. Sorry.
Well, just especially to our fellows that are here and online. So much of what you've talked about here, if you think about the pharmacology and those types of things, it's been a minority of what we've talked about this morning, right? So much. I was taking some notes here. In fact, I held my breath for 30 seconds twice while you were talking. And at time 27, boy, it gets really hard. But think about that. You have the control versus not. And so much of what you talked about, I love the phrase, give control where control can be given. You talk about empowerment, calming. Think about all the stuff our patients and their families are dealing with. If you have both the academic understanding and confidence in the pharmacology, right, the science we stand on, and the ability to lean in there with them to say, to know there are things we can do, that everything's going to be all right, and then make that trusting connection. So much of what has been talked about is, again, that building that trusting connection, and now how we leverage that for the patient and their family's benefit. Well, thank you.
No, thank you. I appreciate that. And, to extend that a little further, a lot of our colleagues, I hear this every day, well, they have to wear it. They have to have X, Y, and Z. pulmonology saying, their oxygen saturation, or the nurse on the floor. Patients don't have to do anything. Our onus is to understand all of this, right? The clinical reality aligned with their lived experience and what's sacred to them, and offer them choices. That's the empowerment. And so when we're caring for patients, please know it's our responsibility to care for our colleagues as well and give them control where control can be given, right? Because we're trained to just escalate clinical intervention. And if that oxygen saturation is not 92%, subtextually, we have failed. The bigger existential question, if somebody dies, we've failed, right? Because we're supposed to beat Mother Nature. But we talk our pulmonologists off the ledge. We talk nurses off the ledge and say, it's okay. To the nurse on the floor, take a deep breath with me, because they're statin at 80%. But this is the path that they've chosen, and it's okay. And in the context of talking with patients and saying, look, everything's going to be okay, recognize it's not, hey, I've got this magic wand and can cure your metastatic adenocarcinoma. No, but given the moment right now, we're going to step back from the ledge, and it's going to be a lot more okay than it was 10 minutes ago. It's not okay in the big picture. I can't, defeat Mother Nature and prevent you from dying, because we're all going to. But I'm going to partner with you to help you live your best life. And again, when we engage like this, whether it's shortness of breath, pain, or no negative symptoms, just dealing with a big ticket item, we're really shifting that narrative, right? Medicine leads with the wrong question. Cardiology storms in the room and says, you need a cath. I don't want a cath. You don't want to die, do you? Well, it's an asinine question. We're all going to. And I don't take that lightly, and maybe not right at the time, but the question should be, how do you want to live? How can I lay out all these options, get away from this dystopian world that we all live in that is medicine, lay out these options so you can write the chapters of your life as good as possible. And I appreciate you were holding your breath for 30 seconds. I know Dr. Mulder's been holding his the whole time, hoping that I don't screw up. So I'm sure he's probably blue in the face right now.
You're holding your own for the moment.
All right, good to know. A question came through. Have I had any experience with buprenorphine and dyspnea? I have very, very limited experience. Full disclosure, I've utilized all the other pharmacologic agents much more readily. I'll turn it back to John and say, John, do you have much experience? And
No.
what is that? Because I can't speak.
But we happen to have our West Michigan expert in buprenorphine here in the room. And I will
tell.
Go ahead, Joel. Floor is yours.
Tim, this is Joel Phillips. I think we met several years ago when you were out here when I was a fellow. So thank you for coming back virtually. I've done a lot of kind of research on my own with buprenorphine, and I use it a lot for my neuropathic pain because of different receptors it works on. With the mu agonism it has, I can see it be helpful for dyspnea. I personally haven't ever used that as a go-to for dyspnea, but if somebody already has neuropathic pain or other pain issues, and you're thinking, I want to start buprenorphine for something like that, it could probably be one of those kill two birds with one stone sort of situations where you could use it for that dyspnea.
Well, because you can do it buccally, and it gets up fairly quickly. Gets into the system. So I would think that's a potential advantage.
Yeah, and again, the thing we come across is the availability. Like, I'd love to use buccal film all the time if I could. Hospice is probably a great situation where you could use it. The insurance companies really play a big role in how we do it. So it's the advantage of hospice.
There you go.
Yeah, absolutely. And that's a great point. It's nice to see you again too. And thank you for not heckling me. If we have the opportunity to kill two birds with one stone, that's really important. And that can't be understated, because the burden of caring for someone can be exorbitant if you're using 47 different medications to treat 47 different symptoms. So I do appreciate that. All right, let's move on to secretions. The trick is to get it right. Not too thick, not too thin. One of the most horrifying experiences I have in my career is during fellowship, cared for someone who had profound mucositis. I just remember walking in there and them struggling to breathe and coughing up almost this spackling consistency, just so viscous material that just almost like bubble gum, stringing it out. And I thought to myself, I hope I never have to experience that. And so again, secretions come from too thin to too thick, and our opportunity is to help mitigate either so that people are comfortable. So a mainstay, if someone's got too much, anticholinergics, drying agents, glycopyrrolate, scopolamine, atropine. I'm going to throw this back to John and our resident superstar pharmacologist right there. And I know that scopolamine is one that crosses the blood-brain barrier. I've seen no studies that indicate it influences cognition, but I have this lived experience in hospice that when there's a little bit of terminal restlessness, a little bit of anxiety, a scopolamine patch, and maybe I'm just making this up in my own mind, compared to glycopyrrolate, which does not cross the blood-brain barrier. I've experienced scopolamine can dry out people and take that restlessness edge off. And I don't know if there's any research out there that supports this, but I'm just throwing it out there for what it's worth. Again, kill two birds with one stone. I would never use scopolamine as a first-line agent for terminal restlessness or agitation, but seen a lot of strange things in my day. You guys had any different experience?
I'll throw this out to the floor before I chime in. We can talk about practical experience and lived experience. Thoughts from the floor?
I would say I agree with that. I mean, one of the things that I think is, that it's not the first goal to the terminal restlessness, but if scopolamine can help you kind of take that edge and kind of, prevent me from having to do more Haldol and phenobarb or something like that, then I'm all for it,
My observations from just the reading is you're correct, across the blood-brain barrier. I mean, it's people use it for motion sickness. If there were a ton of significant cognitive side effects, you would think that people would not be so quickly to use it when they go on their cruise. I think that the couple of things that put it at the bottom of my list, it is on my list. It's just not at the top of the list. Being delivered in patch form, it takes a while to actually get into the system and do the work that we want it to do. And so there's that delay. There's a cost factor when you're talking about hospice patients because you've got better, quicker options than scope. It does cause some sedation, and so as you say, is there an opportunity to capitalize on that particular side effect? I think that generally the literature probably discourages it. Practical experience would suggest that, it should be somewhere, just an arrow somewhere in the quiver that we may need to pull out sometime.
I appreciate that. And for me, it's not first line. At home on hospice, atropine drops. But I preferentially like glycopyrrolate. But just knowing all the ancillary effects of medications we give, again, is beneficial as well. So expectorants, drying agents, again, anticholinergics. We can use aerosolized agents, hypertonic saline, sodium bicarb. One of my Achilles heels as a clinician is pharmacology. And so if I'm diving into these things, I always, even if I've used them 5, 10, 1,000 times before, I get in touch with my clinical pharmacologist and talk it through, as well as my pulmonologist and the other people involved. Beta adrenergic agonists. You can use Mucomist is a mainstay for a lot of my team in the hospital, as well as a lot of the pulmonologists. Enzymatic agents, I've never used recombinant DNase. I understand how it works, but know that there are many, to quote John, arrows in our quiver beyond a scope patch and glycopyrrolate. And again, let's come back to just 100 level medicine. If you have an infection and there's an opportunity to treat it with an antibiotic, that should be considered. You know, let's be smart about what we do and not always run to, you know, recombinant human DNase, because maybe it's a little more sexy than just a first line antibiotic. Non-drugs, suctioning, again, the empowerment, giving someone the ability to suction themselves if they have the capacity is a game changing in the acute care setting, as well as hospice at home or other settings. I have never been, and I would advocate for not suctioning the obtunded patient who has the proverbial death rattle. Doesn't do much, and not a big fan of sticking a big ink down somebody's throat and potentially causing a lot of discomfort. This comes to the education component and lived experience again. We'll touch on it a little bit later as well. End of life, the death rattle, the secretions that are audible, empowering family members and caregivers to understand that this is a very natural process is important. My lived experience again is all our anticholinergics sometimes are ineffective in mitigating that sound. And so making people in the room comfortable with it, and to the best of our knowledge, sharing that I don't have any experience that patients are struggling because of it, and they still look very, very comfortable. It's just hard for us to hear is very important. I reflect on caring for my wife's father-in-law here at my house, our house here about 5 years ago. And he was in our bedroom. We put him up in the master bedroom, and he was actively dying. And it was a very comfortable journey until I suspect he had some sort of acute cardiac event and lost all his blood pressure and had flash pulmonary edema and went from being very quiet to sounding as though he was drowning. Secretions in the posterior pharynx and elsewhere that you could hear 3 rooms away. And so, again, being that calm, cool, collected person, that little proverbial Fonzie from Happy Days coming in and just making sure the temperature of the room doesn't rise so that people can be present and not get dyspneic themselves because of the sounds they're hearing from their loved one is very, very, very important. And we didn't have the ability to suction, and it wouldn't have done any good anyway at that time. For our non-hospice actively dying patients, postural drainage, chest physiotherapy. Again, we talked on positive expiratory pressure devices, external compression vests. Think of your CP patients, as well as hydration. It's interesting, hydration doesn't, the studies I've read, doesn't appreciably change whether someone becomes too dry. It can certainly influence somebody becoming too wet. And that conversation is, look, we need to keep them with IV fluids because I don't want them to become dehydrated and suffer to the end of their lives, understanding that too much fluid could leak into spaces we don't want it and cause some shortness of breath as well, and people to suffer is an important conversation. External devices, we see these used all the time. Post-operatively, how can patients be empowered to keep things moving, keep their lungs clear? Sometimes I just have patients blow through a straw, increase the differential and pressures internally and externally to help them clear out secretions if they have the strength to do so. We talked about the death rattle already. Again, education. Be the little Fonzie. Walk in the room, be calm, cool, and collected, and help everybody else be the same. xerostomia, sugarless gums and candies. Understand the mechanism of how they can help keep a mouth moist, but know that we need to look at their medication list to see if there's anything that is contraindicating or antagonistic to what we're trying to do. Is there an anticholinergic on board for any reason whatsoever? Maybe we're not utilizing it because of excessive secretions. And maybe that's counteracting our attempt to keep somebody's mouth moist. At the end of life, empowering, again, I have this conversation at least once a day. Let's use a swab to keep the patient's mouth moist. It looks like their tongue is sticking to the top of their mouth. Their lips are really dried. This is very, very different than being dehydrated. This is not when we hang some normal saline and run it at 250 an hour. Let's just use a swab to moisten the mouth. Let's use a little bit of chapstick or other to keep their lips from being too dry, and empower people to have control over this process. They're walking with their loved one. There are cholinergic agents. Again, check your med list. You don't want to have a yin and yang going at the same time and wonder what's going on and why nothing's working. Saliva substitutes are an opportunity. Cannot stress this enough. Optimize oral hygiene. All the stuff that just normally lives in our mouth and flies in our mouth, particularly in an acute inpatient setting, where are all the germs? At the hospital. Just know that let's keep the mouth clean, keep it moist to an appropriate level. Here are some opportunities for us to use different types of mouthwash for patients to be very comfortable. And again, in this end of life, empowering somebody to be present and touch their loved one and care for them helps them have a sense of control. They're walking this journey. They are providing nurture. This is a way for them to feel love and honor and respect their family member, their spouse, their child, their mom, their dad. Is very, very profoundly important. Don't just leave it up to the person. Give family members an opportunity to be intimately involved with the care of their loved one. All right, I know we've got just a few minutes. The primary thing today was dyspnea. Let's zip through cough real quick. It's a defensive reflex, airway irritation, phrenic and spinal motor neurons, recurrent laryngeal nerve, anything tickling that can make us cough. Think of the intubated patient who we're looking to liberate from the ventilator. One of the things we check is, do they have the strength to provide a deep, deep cough? Can they create that negative pressure to clear out their airway and keep it clean so we don't have to re-intubate them? Do they have good mucus and ciliary action? Are there genetic things that are preventing us from having good ciliary action? And understanding how that influences the journey is very important. Chronic and persistent symptoms. If you have people who chronically cough, they're tired and they can hurt. Think of the intercostal muscles, right? These are thin, tiny muscles. And if they're constantly being exercised, they can be pretty darn sore. It's like training for a marathon every day. You can feel short of breath. Sometimes you can cough so hard that you throw up, keeps you from sleeping. At my age, I worry about coughing and wetting my pants. I'm getting to be that age. So all these things to be mindful of and to ask your patients, are these a lived experience? How can we help you live better? Protussive treatments, guaifenesin, hypertonic saline, beta agonists, mucolysts, chest PT, vests for neuro patients, etc. A whole plethora of engagement opportunities to help our people live better and clear out what's going on in their lungs so that they can decrease that experience of coughing. Opioids. So again, if the goal and the concern is not we need to clear out secretions, we have some infection, if it's just persistent cough, what can we do to kind of dampen that? Opioids can do that. Maybe you have an infection, but you're short of breath. And so again, this is the art of medicine. This is where all of our expertise comes into play. Understand that the opioids can still be very beneficial in lived experience, but not contraindicated if somebody needs a cough. And so playing with that while you're in training, being comfortable with that's important. Codeine, hydrocodone, methadone. I just have to say, disclaimer, had a provider who was using methadone as a PRN, 10 milligrams every 2 to 4 hours as needed. No. Become experts in these medications that are very efficacious when used appropriately, and learn to train and teach our colleagues as well. So dextromethorphan, Tessalon pearls, lidocaine nebs. I have never used an SSRI, Paxil, for this purpose, but there's some lived experience that it ancillarily helps patients live better. And I know I'm going pretty quickly here. Decongestants, antihistamines. Again, remember, people with lung cancer can still have an allergic reaction in the fall and the spring because of what's going on outside. They can get a common cold. Use all these tools at your disposal as well. Radiation therapy, other treatments. Use a broad perspective and engage all of our colleagues to see what opportunities exist to mitigate negative experiences for our patients. I throw this in mouse of fatal hemoptysis. A lot of times our patients we're dealing with who have these persistent coughs, maybe it is something going on in the esophagus and around there, or big vessels in the lungs. Just as a note, educate patients and families.
It's gonna be 70.
Did I miss something? Okay.
I think you're okay.
All right. And I approach this, and I've had, unfortunately, about 4 people over the last few months who've had fatal hemoptysis from popping a big vessel. And I approached it saying, look, blood is a fluid, much like water, much like urine. We do have this emotive response. You know, it's Friday the 13th, the horror movie, when red is being spewed all over white sheets. So really encouraging patients, family, caregivers, and nurses at the bedside to recognize, let's be little Fonzies, calm, cool, and collective. Let's use dark sheets, dark towels. Let's mitigate that emotive response if there is a lot of blood. And let's push an anxiolytic or some other thing very, very quickly if that should start to happen, because time is of the essence. Last thing we have is hiccups. It's a reflex arc, afferent, again, from the body to the brain, phrenic, vagus, thoracic, sympathetic, anything going on in the lungs, chest, tickling those nerves, telling us to hiccup, central mediator in the central nervous system, the cervical spine and brainstem. What's coming back out is the efferent limb, motor fibers of the phrenic, and give us this reflex arc to hiccup. If it's greater than 48 hours, it's persistent. I've only had about 2 cases over 20 years with some intractable hiccups. And I tell you, I put it up there with intractable nausea. People say, Doc, I can't sleep. I'm miserable. I can't talk. I can't interact. I can't eat. It is profoundly disturbing and inhibits their quality of life. The reality is there's no magic wand. There's nothing that I've found that successfully time and time again can mitigate hiccups. And I'm going to ask my colleagues to chime in and educate me what I'm missing. We can probe, we can look for fusions, tumors, try to find an underlying etiology. It's the first step, and see if we can mitigate that. Is it a neurologic issue? Stroke, tumors, sarcoid? Are there things that are reversible, metabolic, toxic? And again, usually the etiology is unknown. And while I go in there and I say, let's drink a cup of water standing on our head, or try to scare them, those old wise tales of mitigating hiccups, nothing really works. Most of the time, thankfully, it resolves on its own. But occasionally in your career, you get that one that is just persistent. Just go through your list. Talk with pharmacy, talk with pulmonology, and just start checking the boxes. Go through the arsenal that is at our disposal to see what works. But again, educate and empower and say, I'm going to keep trying, right? One of the things we have the opportunity to do with our patients is say, I'm not going to give up trying. If this doesn't work, I've got some more tools in my kit, and we're going to keep trying. Okay. And right there, patients feel this sense of, wow, okay, I got somebody in my corner, and it's not as bad as I experienced standing by myself in this loss of control. I always reach out to pharmacy when it's, again, beyond my scope of practice, and I've run through this list and nothing's working. Home remedies, self-palate stimulation, surgeries, phrenic nerve block stimulation. Again, acupuncture. I want to jump back because I forgot to mention back in mucositis. I've read some studies that show that organic honey in a small amount, while honey itself is a viscous entity, I've had some positive experiences with using organic honey to decrease the viscosity of some mucositis. And it's believed in what I've read that there's some enzyme that's produced in the bees that's in this honey that helps break down the bonds in the mucus that people are experiencing. It makes it a little less viscous. I wouldn't give them, a big tablespoon of honey, but certainly if somebody's not allergic, a dollop or two on the tongue has a very low risk and certainly can be beneficial. I've had it work 2 or 3 times in my career. All right, I stormed through the last few things very, very quickly. I am going to stop sharing my screen right there and go back to this is me. Hi, everybody. Any questions, comments, or concerns?
Anybody go for questions for Tim? I got just a couple quick ones. Questions and comments. In the sialorrhea, one of the little things that you could add to that for the more in our palliative patients, not so much our hospice patients, is Botox.
Absolutely,
We also happen to have a Botox expert here in the room, so we just want to make sure we acknowledge that. On the hiccup thing, the fact that you have such a long list of potential things, a lot of times it's just like, it's this mixed salad. Well, which do you do? And when? And so I've just sort of adopted, a lot of times I try to think more simply and streamlined. For hiccups, all those things, everyone on that list, if you can find an article that says it helps. I use baclofen #1 and I use nebulized lidocaine #2. Almost always. Yes, people use Haldol and other antipsychotics. People have used gabapentin, but I found baclofen will do 75% of the time. It will help, and if that doesn't help, then I use the nebulized lidocaine. But you have to use enough of it. It needs to be 100 milligrams, and which you need to find the 4%. You can get 5% if you want, 4 or 5% IV solution, and then use either 2 or 2.5 cc's of that in the nebulizer, and it works great. So those were one. That was 2. The third one is you put an extra assignment on our plate here, because after we're done with this lecture, I need to explain to a lot of young folks here who Fonzie is. So
I'm sorry. I'm sorry. To the group, Fonzie is a character from a television show in the 70s and early 80s called Happy Days, about a family in the Midwest. I believe it was Milwaukee, a family in the 1950s. And Fonzie was the leather jacket, smooth talking. He was cool, which again is nifty, groovy, hip. I don't know what the current language is.
Vague understanding.
yeah.
Henry,
All right.
and you'll see the statue. There's a bronze spons.
Bronze spons.
Oh my God.
The phrase jumping the shark. That's Fonzie.
Well, thanks again, Tim. Appreciate your being here. Again, I would encourage those who are listening to look up his TED Talk. It's a wonderful summary that will just validate what you understand, believe, and know about our field. And it's a really great resource that you can share with others who you're trying to educate on the essence of hospice and palliative care. It's a short one, but it's really, really good. So Thanks again, Tim. Appreciate you.
Thank you, John. Thanks, everybody.